and we're going to go straight to the cath labs across the highway, and I see a very stenosed coronary artery. Paul, we see you.
Well, good. The timing's right. Your perfect timing. Just finally found a guy that worked. 73-year. Well, welcome. First of all, good morning.
Sure. Let me introduce your panel. We got Dave Ryzek. We got Darshan Doshi. We have Jeff Moses and Bruce Samuels.
Terrific. Good morning, everybody. I hope you got some sleep. I've got Perry Wu here, who was Mort Kern's ex-fellow, and then Matt, we've been working together for 18 years now. I can even recognize him with his mask on. So the case today is a 73-year-old with vascular disease. He clearly has angina. He had a stress test that led to a angiogram. Recently, about 10 years ago, he had stents put in his left coronary artery. His left coronary artery looks really good, but he has this problem here. And the question is, what do I do about this? So this is a right coronary artery with a big rock of what looks like calcium. I don't see the IVUS on the table here, guys. Is there an IVUS made up here? That sort of my latest thing is if you open an indiflator, open an IVUS for me. So he's symptomatic. This is a pretty challenging lesion. He was sent here for us to do this as a team here. And I have my ideas about how to start this. I didn't want to wire it till we got on camera because that could be difficult.
Do you want to go across the panel while you're looking here?
Let me give you the other views, and they don't tell you very much. Well, one thing I could see, Schatz taught me this. If in this view, the coronary is not going posterior, if it's not going to the left of the screen in its initial takeoff, that's good. Remember the old days we had stents that were very hard to deliver, and it's when the coronary goes backwards that it's going to be hard to deliver. So this might be easier than I think, I'm hoping. And there's another view, doesn't really help much. So we'll go back to the other one. Okay, so please tell me what I should do.
All right, so first, your right radial, and that is a 6-French AL guide with side holes, is that right?
Well, actually, I asked for a 7, thinking this, I don't know why. If we end up doing rotablator.
Yeah, sure.
I just thought we should do a 7.
So you have a 7-French slender in the wrist.
So this is, sort of like the new sheath that I guess is going to come to TAVR. It's going to be a little smaller because it's skinnier. Also I should point out I'm not wearing lead. That's why I'm in a good mood. I got the Rampart. And that's the setup. So,
all right, so Darshan.
We've done everything radial so far, by the way. Yesterday was all radial. It's, we haven't gotten femoral yet. Yeah.
Darshan, what's your approach here?
Yeah, I think this is going to require some form of atherectomy. I mean, you basically have multiple rock piles there, and support is going to be the key. So I think the fact that you went with an AL, went with a 7-French, I think is going to be very helpful. Wiring that is going to be challenging, and I think you're going to have to atherectomize out. So the question is, what you're going to try to wire with. Obviously, you're going to start with a microcatheter and a workhorse wire to try to see if you can get through and then switch out for a rotafloppy. But it may be challenging to even wire that with a workhorse wire, and then I think you're going to need a more lubricious wire, like a Xi'an black or something to get through, and then spin your microcatheter down and do what you need to.
Okay, microcatheter, Xi'an black.
So before,
Emmanuel.
Can I just interrupt and say, first of all, great points. I usually have the fellows, get everything ready, and we went over the film last night and said, let's get the guide at the ostium, but let me be there when it goes into the ostium for obvious reasons here. That was a good point that Darshan made. And the other question is, I've already asked for I have a workhorse wire. I've already asked for, oddly enough, a Xi'an black on the back table, but I'm also thinking maybe even a Mongo for this thing once I get the nose in it. I mean, this may be sort of like a CTO. But those are really good points. I don't know. Let's see what other people think.
Yeah, Emmanuel Berlakis is here. Okay. He's written books on complex intervention. So, Emmanuel, what do you think about this?
Well, this is actually a repeat from yesterday's case, maybe a little less extreme that Paul did, the last case yesterday with the calcium and tortuosity. Of course, the difference here is you have a bigger vessel, so you have a little more to work with. But I agree pretty much with what you just said. Microcatheter, workhorse first, Xi'an black if it doesn't work, atherectomy, you may need shockwave, and then stent.
Jeff,
So does anybody think we could do this with just shockwave?
Well, I think, let me just take a bit of a different, it's David Reisig. I always try and see what I can get with a balloon first, and then if I can deliver a shockwave. And often I'm surprised at how these things dilate. Now, this may absolutely come down to high-speed rotational atherectomy. On the other hand, I'm often surprised what you can do. Herms and I did a live case like this last year, and it looked identical to this. And we used an AL just like you're doing. And incidentally, I love the way your AL is sitting in there. You're not, you have the ability to engage that more, but you're not for reasons to not damp that pressure. But I'm often surprised what you can do with a balloon and shockwave, but it may come down to HRSA.
Okay, any other, these are the high points.
Jeff?
Guys.
Yeah, I would want to see what the bias of the wire is once you cross. And frankly, to me, this may be a very eccentric large nodule sitting there. There's obviously another one downstream. And if you had the appropriate bias, this may be an opportunity for orbital to really shave that thing off. Because I don't know how much, the jury's still out for me on these, if this is really an eccentric nodule.
Right.
How well shockwave actually works.
Yeah, this is what we talked about yesterday. Evan gave one of his 27 lectures yesterday was on what do you do when you see IVUS and you determine what type of calcification you have. So I think that's the first step. You really want to know if this is a bad nodule or if this is just circumferential calcium, eccentric calcium, deep calcium. All those things are going to make a difference, I think, in deciding which way you attack it.
So what I'm going to have to do here is get this on, go on the
But Paul, one thing I wouldn't do, honestly, is I wouldn't use a Mongo. Only because, that is built to fold. And here I think you want something with more linear push.
Well, yeah, I was thinking about using it just straight, but
I know, but I'm saying if you run up against something, it's literally built to knuckle.
That's a good
And then you're in a whole different place and you need dual access.
so you see one of the problems here. Let's just put this on Senate because you give a medium shot here. I'm sorry. Here we go.
Would you start with Sheon Black?
So I don't think that's the right passageway. Do you? I think I got to hug the inferior border somehow of that vessel. Let me zoom this up and maybe a little.
There are a couple of channels there. So already, although I like the idea of getting a wire down and seeing if a 2.0 balloon would cross and go to shockwave, already now it's looking like this is going to be a rotational atherectomy case.
So what do I think here? That is a branch vessel on the bottom. So maybe, well, no. Let me just show you what I see. See how that's a good picture, right? That's
And
not the
maybe
way my wire should go. The wire should be lower. Do you all agree?
Yes.
Okay. Now the question is, how do
I'm
I
not
get
sure. There may be a
yeah.
zigzag there. I don't know.
Yeah, I think there's multiple
I think it's
channels.
too hard to figure out in one plane.
One thing Paul has to be careful of also with his guide is to make sure that he doesn't dig the wire in subintimally there, which he hasn't done.
Exactly. Just there a second. I just went up to Mag 3 so I can see this a little better. It's going to be a challenge. Boy, I tell you, we picked the challengingest cases here.
It's better than a cup of coffee to wake you up.
Not gonna work. Is there?
There you go.
Okay, so that is better, right? So let's make a picture of this, make sure it's better. I'd love to get my Turnpike LP into that. What do you think?
Yeah, that's getting there, right?
Yeah, that's getting
That's
better,
one
but I have to
possible
get it to
pathway,
advance.
yeah.
I think I'm going to have to do that with a Sheon Black to get this to work. I need to get a little bit more purchase down there to get my microcatheter into it. Test there a second. I think I'm in the wrong place there, right? No, I'm in the right place.
So, Emmanuel, any differentiation in terms of the microcatheter to use in this particular case?
Yeah, you can use anything. Here, what you might actually, it might help you is an angulated one. The Venture is no longer available, but there's the Supercross. There's another one called Shape It that just became available. So having an angulated will give you that extra bend to go in the down part of the lesion.
Do you think I can get this? This tip is where I want it to be. That's a really good point. That I didn't think about using a Supercross. I was be a little nervous about it being a little stiff, but maybe not. So I would love to see if I can get this to this. And then give me that Sheon Black. This won't go any further down in here as we kind of predicted. So let's see what happens here. Now test there. Does that make it go up? Not yet. This might actually work. Okay, so let's see if I can. Let's just get the Sheon Black and see what I can do. I need another.
One thing I wouldn't use is a Caravel, and what I would use is something
that
low
one.
profile, just so the tip will track. I wouldn't use, a spiral or something like that.
Say, I'm sorry, what would you use, Jeff?
I wouldn't use this. I would use like a Corsair Pro XS, something just a low. That'll be more flexible, and if you're going to have a soft part of the wire there, maybe you'll be able to get it to track over it.
Do you think that there's a difference in flexibility to the Turnpike LP and the Corsair XS?
Not a lot. I just think the XS has a little more push.
So one thing I would say, Jeff, is there have been cases where, I can't spin any of the microcatheters through, whether it's an XS or an LP, or, you go with a more heavier bodied microcatheter like a spiral. And the lowest profile microcatheter we do have is the Caravel, and in some cases it's actually been able to get through when other catheters haven't.
Yeah.
With that being said, it would definitely not be my first choice. It'd be my last resort.
I'm just worried about the tip.
Yeah,
in
the
that,
tip getting-
stuck
yeah,
in that calcium. That's all.
I think it got pulled. I don't think it's where I want it to be. I'm going to pull this back.
And another option here, and again, I would still do the black first, would be to use a SUO3. That's a very low tip gram wire, and that's very soft and traumatic. So that cuts back on the risk of dissecting it. But I think the Sion black is what most people would use.
Just here. So that's not going the right direction. I'm going to push the guide down a little bit. So, I'm trying to get into the, okay. Now this is going to probably make this go a little bit in the wrong direction. This is, okay. I'm trying to get this wire to do what the last wire did.
Which wire is this?
This is a Xi'an black,
This is the black? Okay.
but it's not as steerable. So what I need is a
There you go.
steerable wire. I said that's going to be the upper branch. See, I don't think that's the right branch. So I could take a bigger bend on this wire. Suppose I can try Baracus's idea. Now, is that right to test there? That's still not quite in the. How about if I put a secondary bend in this wire to see if it'll go down?
Paul, I don't think the top or the bottom necessarily is the right one. I think you just have to see where the wire goes and then sort of follow it through.
Yeah.
Well, does everybody agree with that?
Yes.
Okay, really?
Yeah, I'm looking for charity. I'll take whatever I can get in this one.
Yeah, take whatever you can get, Paul.
Yeah.
Maybe a Pilot 150 or something
What's
a
the
little more
difference between a
200?
Pilot 150 test there?
I think you got a big rock sitting in the middle of the river and the water's streaming around it, and whichever direction it goes is going to be okay.
That looks like
Test there? See, I think that's not in the way that I think this. Yeah, that would be great if it went down, but it could also really dissect it and get me in trouble too. So if I just sort of let a manhandle this thing, that's not going to work. All right, so I'm going to try to put a secondary bend on this and see if that works. I mean, and if it doesn't, I may take Berlakis's idea and see what I can come up with.
Yeah, the one issue with the angled microcatheter is it's just not going to give you the pushability or the crossing profile. So, I mean, you may be able to get it started, but then you'll obviously have to switch to a more torqueable microcatheter.
Sure, for sure.
if I'm confident on the channel, which I'm not, but sometimes what I'll do with this is like take a Miracle 6, just because of its body, and just get it to a point where where the micro will actually track and get into that entry point, and then work
that's a
from
really
there
good idea.
with a jacketed wire.
So, Manuel, just if I were to use a Supercross, would you suggest the 90 or the 120 for this?
Yeah, quick point. To be honest, we typically don't use anything else except the 120 because by the time you get it in, it becomes 90 anyway. So typically we only stock the
I've heard
120.
you say that. That's why I rose the question. Okay, test there again. Am I still in the vessel? Not so great, huh?
And I think here you might be a little too deep there and might be biasing you,
Test there again.
the guide.
Yeah, I think I'm a little down. I'm trying to aim for the inferior border, but test there. To do that, I have to pull back. Right, I can't. Let's make sure I'm not hurting anything here. Okay.
Push in.
My rampart's attacking me again. All right, here we go. I want to make sure I understand what I'm doing here. Okay, so what? Now I have to. It looks different now, doesn't it? Maybe the guide's in deeper. You think? You think that's what it is? I don't think so. I don't think so. Let's see what I can do here. Come on, guys. We should be able.
But that sort of confirms what we think that channel is, don't you think?
Yeah, I think it looks more clear now.
Yeah, you may have knocked off a little thrombus there.
That may be.
Looks
what
like
happened.
brisker flow.
I can't get the guide wire to come out of the guide though. So that means and this is a Xi'an, so I don't want to dissect things. All right, so let's pull this back a little bit. Give me a test there. I just pulled the guy back. Maybe I'm in too far. Maybe Manos is right. Test there.
The other option here might be to switch for a JR. I know we don't like JRs
Yeah,
for
I'm actually
complex, but
thinking of that, right? That's exactly, you're reading my mind. That maybe I need to
Yeah.
get down with a JR and then I can switch out if I have to. Let's get a JR. I think I asked for
that's a
that
really good
on
idea.
the back table already earlier. Yeah, let's just do that, all right? Give me a exchange length before I get into, what's gonna, you all see what can happen, right? This is
Yep.
gonna end up being a dissection that closes the vessel. And then I've got an urgent CTO that I have to deal with. Okay. So I'm going to switch guides here. And the question is, so you have to tell me what's going on elsewhere.
Yeah, I think-
Sometimes guide wire passage can be boring, although you guys are giving me pretty good hints here.
Well, let's do this. You got to switch out your guide, get that engaged. And we can, why don't we start with a talk and then interrupt us once you have all your equipment get ready to go, okay?
Yeah, that sounds great. Okay.
All right, thank you.
I will stop. Paul is ready.
Yeah, I mean, Shami, I'm really sorry. I know I was going to break in your intermediate, but let me just tell you what happened. I put a JR in here, and I still can't get around that bend. So my tech said we got a couple of leftover venture catheters. So I put the venture in, and it's been a real struggle. But I think I've got it now where I want it, like right here. So just give me a test here. And I really could use your help here. Oh, wait a second. It's not where I want it, is it?
No.
What do you guys think? Should I push on here or should I try to get it into that lower? Here,
you
let me
pause
give
it?
you the. This is really tough. This is really tough. So,
I don't think you're quite in that channel, Paul, that you're trying to get into.
yeah, see what? Oh, yeah, see? And here I was all excited. I interrupted you. Okay. This is, you see what the problem is? I have to go up and down.
Yep.
Near the guy. Yeah, that actually shows the problem really well. Can I fail on 2 cases in a row? Okay, I'll continue to try to get into that lower branch. And I think that's going to be Manos's idea next. Anybody else have any ideas? Better operator?
Eventually, a Gaia.
Yeah, maybe a guy will sneak down there.
I wasn't trying to sneak down there. I was
The venture
your way
is sort of
through.
venture is not helping me as much as I thought. I mean, it just doesn't. I've got it. I've tried unbending it and bending it, and
I think if you could hook the venture in that inferior direction, maybe, because it's. I'm
that's
surprised
the
you
whole
still
idea.
have those.
Try
It's
to
like,
get it to form like a micro.
that catheter.
Yeah, like a micro amplats. This is really killing me. This case, just to get the wire down. I thought I would get that easier. Be honest with you. I've wired a few vessels before. This is not doesn't look that hard.
I kind of like Manos's idea because now it's
That's better.
Well, no, it's
Adventure's a little unwieldy sometimes.
just so. I think
maybe easier to turn if you straighten it out and
Yeah, I've
then
been doing
redirect
that.
it and then
So
rebend.
here's it straight right now. Let me do it again. Straight now. That looks better. It has a little turn on it, even when it's straight. And test there. Is that? No. Now it's going into it's dissecting the ostium. That's what I don't want to have done. What happens? Yeah, this is really tough. Okay, so maybe now that's up into it. And then we turn it down here. Test there. You know, the Xi'an black does not turn. We need what is the most lubricious wire that is also steerable?
Well, a hypercoat might be an interesting option here.
Hypercoat
A run-through hypercoat.
run through. Okay.
It's not polymer jacketed, but it is hydrophilically coated.
So I'm going to now turn this. What I'm going to do now, Jeff, is I've got it up in there, right? Test again. I don't want to dissect them. Yeah, I definitely got it up in there. So I'm going to take the wire back and maybe turn it and maybe see if I can. I'm going to turn it to the right here, twist it to get it to make a bend. Now it made a bend, but in the wrong direction. And then when you see when I flip it, it flips like momentarily only. And that's going in. No, that's not going to help. Okay. Oh, you see this, how this is not working? You think it, no, it just spins around. It just doesn't like to sit there.
Yep.
And test here.
Oh. Better.
That's
Looking
better.
promising.
So if the wire would just go down instead of, and I just don't, I know that if I just slam this in here, it's going to be a mistake. Test there, is that kind of better?
That looks better.
Let's send it because it may not be as better as you think. Inject. No, that's actually better.
That's good.
Okay, and now I have to somehow get this wire. Should I straighten out? No, I should leave the bencher where it is. It seems to be doing what I want. Okay, so let's get a Mongo on.
I would try a hypercode. I mean, it's a
Run
little
through
bit
Hypercoat. Okay, we'll try a run through Hypercoat.
because you're not going to. The likelihood of dissecting with a hypercode is incredibly small.
Okay, I'm going to quote you on that.
But you can also just wire it right here. Oh.
It's out. Okay, you don't get a lot of support here, which may be good because I'm not going to be less likely to. So we'll try the hypercode, and then we'll try something else. Then I'll try the 120, see if that sits better. What I don't like is I've gotten pretty far along, and I don't have a lot of good ideas here. It's rather annoying. Okay, so let's try that. And all right, tell you what, stick with me for 2 minutes to try this, and then we'll get back to the talk. And then the next thing I'm going to try is the 120. Any other ideas? So you guys
So
have
Paul,
for us.
with the run through wires, it's really important to use the shaper rather than what you're doing there because it won't.
Okay,
I know
where's
you
the
hate.
shaper
I know
that
you
goes
hate
with
the
the device?
shaper. I know you hate the shaper, but it's important
Just
to
stay
use.
now. It's just. Thank you for that. I don't use these wires much, so I got to make this into like a deep bend, like just one. I can't make it. You don't like an angle either, right? You like it to be kind of curved.
Are there any collaterals from
why
the
is the
left?
shaper so important? What do you think?
Because it's a nitinol tip, and it's the gauge of that needle of the shaper is much smaller than your introducer.
Is that? What do you guys think of that? More? Can you see it? You just got to zoom in there, Mike. Steve.
Yeah, you can see it.
Is that good? Or you want more?
I'll let you know in about 30 seconds.
Okay, I'm going to make it just a little bit more. But what do we do if I can't get through this?
So, Paul, are there any collaterals from the left side? Because if that's the case, then there might be an option for going retrograde.
Yeah, you're right, actually.
I mean, it's not a bad case for ADR. What do you think, Manos?
One of the attendees mentioned a Fielder XT.
Yeah, that's a smaller. That's a smaller.
I don't know if that'll have the body to work its way. I generally
Try
don't
to-
use the XTs for this. Usually XTA,
Okay.
more
Do you-
steerable.
XTA is more steerable, right?
XT's more steerable. It's,
XTA, I use the XT mainly for knuckling.
all right, he's moving around now. I don't like that. All right, let's test there. Boy, it's the stress. So let's get this out. So it's going in the right direction.
Yeah, and I think another option is to use like an IM or some sort of guide that, or hockey stick that points.
You know,
out.
an IM is not a bad idea. Is he okay there? Because he's moving a little bit, and that's not going to help me. Test there.
Or a guide extension maybe that can come around and help you get over that bend.
So really good ideas. I need a bigger, well, you know what? I need to either get a bigger bend or get this venture out and see if I can get the venture to bend and point this wire up. This is like,
There we go.
see if that helps. Up, test there. That should take me to where I want to. You just put it on, Cindy, so I can see. Inject. Okay. Well,
It's just such a hairpin turn there. Wow.
wow, yeah. I mean, it's rough, and I feel like I'm digging up the bottom of that already. So I really like to get this wire down there. It might me feel a lot better. I just see what happens there is the guide just comes out. Oh boy.
Let's see where wire is there. I think. Yeah.
That's a good spot.
Yeah, but look at the venture pointing, making it worse.
Yeah, but I think you're basically bouncing off the back, which is what you need to do to make that turn.
Test there.
You're ricocheting off the back.
Like, why is this so hard? Okay.
There.
Get to that view, then we need to take this around and point down.
Can't get your boat.
I'll pull the wire back and see if I can get this to turn around, which I have not been able to successfully do. I think I'm trying to try the 120. That's his idea, because I can't get this to stay in the downward view.
I guess, do you have to? Can you use it pointing up and then sort of use the back of the
Yeah.
Of the
no, it's not
vessel.
folding over that. Okay. This is not just going to jam through there, I can tell you that. Okay.
I
let's
think
get
the Supercross is a
120
good
and
idea.
then
It's
yeah,
much more
Supercross 120,
atraumatic,
then
and you'll be able to sort of direct
why
it
don't we
down.
continue to do the test there? Yeah, this is not going to work at all. I'm going to make it worse.
What
Okay,
about maybe a shorter JR? This is what a JR4, or what is this, JR 3.5?
This is a JR3 at 0.5, right? Yeah. Yeah, I think this
A
one.
JR3 to point up more?
I think, you know, you know what? I'm going to do that. Let's try the Lima. What do you guys think of a Lima guide?
No,
Yeah, that'd be
Yeah, it
good.
should point up a little bit more, which I think may be helpful.
Okay, let's do that, and maybe I'll come.
Paul.
Yeah, we might want to do that at lunch if there's time. Bill's got a great talk, but we'll see. All right, so I left you probably around here. We tried a JR. We tried, and then we actually went to an AR. We tried the Lima. Didn't help at all. Actually, made it worse. We tried an AR, and that's where we are now. And I definitely just need some guidance here. I'm going to get you to my last shot. I've got a kind of hyperbent, multiple bends in a Mongo, and I'm struggling. You can see that's the wrong. And I might end up, one question is, should I push through that? Where I am right now, you've got, I tried an orthogonal view. Sean thought I should try that. I don't know if that helps me. But let me tell you show you where we are right now. And I'm going to try to take this 120, that was Manos's idea, and get it down here. And just want to stick with me for 3-4 minutes.
Yeah.
If this doesn't work, we'll try something else. And, okay, so that's aiming in a position, right?
And this is the Mongo wire still,
Object.
Paul?
Well, it's aiming, it's too proximal, obviously. So let's see what happens here. I mean, I must say, I'm shocked. And I looked at collaterals. There's an epicardial collateral to a PL branch up from the circumflex. It's not exactly an ideal collateral. Okay, test here. Okay,
It's got to be careful. That might be a little flap.
that's more than a little flap. Test there.
Okay.
You know, I kind of get these positions and it looks hopeful, and then let's see if this can track around, if I can twirl it a little bit when I track it to get it to point down. This is what the venture wouldn't do. Wow, this is hard stuff, man. It's not really pointing.
Well, you might want to think of a Gaia second.
That's what I was.
Gaia second. So that's a total occlusion wire.
Well, it's
And the question is, if I get to this position again, like this position,
Yeah.
probably gonna be the upper branch. Should I just try to power through? That's sort of what you're getting at. Ooh, you don't want me to do that, do you?
No, I think you're probably in a dissection plane there.
I mean, so if I do that, I may end up having to stingray and all that stuff.
all right.
I mean, do I do that, or do I talk to the patient about that first? Boy, this is a real challenge. Sometimes I can get side by side to that thing. I would have thought the 120 would have been better, but it's not making enough of a bend. Test there again. Is that going to the upper one? Yeah, it's still. I did the best with a micro, with a turnpike LP and guide wires, I think, so far here. What about there? Test there.
Okay.
If I could just I've got a super bend on.
But no, what if you just take like that, just take the backboard, so to speak.
I'm trying to. Now let's take a picture here. See where we're going. Oh boy, that's
Yeah.
the best I've ever been. Okay.
I wouldn't move anything, right?
Well, I got to move something, or else I can't get the.
Oh, the wire. I mean,
You know, I would like to just declare success there.
yeah, okay.
There we go.
Listen,
Wow, Manos.
I actually had about 30 seconds ago. I had a vision of applause just in my head, what it's going to sound like when you
Now, that was
crossed,
good too.
and there it is.
Hey, I want to tell you something. I said it yesterday. There's these cases, I could not do them without the panel. Someone should just keep track of the times that the panel helps. It may be because I'm getting so bad, but the panel is amazing. Also, I want to give credit to the Mongo that I hyper-shaped. I don't know if Bill's around, but he'll get a kick out of that. All right, so now I've got a Supercross. Now, Manos, just help me here because I'm always afraid of dissecting proximally, so I use a Supercross, but the 120s I haven't been using much until
You know,
today,
maybe
and
you
I'm
want
gonna
to
start using
just take it out and
them.
use the
It's
regular.
gonna go down?
So, Manuel, what should he do?
You know, I would probably just take this out and use your regular
just swap it out.
Corsair, whatever you had before. I'm not sure you need the.
So you don't think I should do what I'm doing now? Take it down. You don't think I should
No, I
take
mean,
it out?
yeah, probably not.
I would swap it out for.
So everyone wants to swap out. We're taking a
Corsair
survey because Emmanuel is here. We're taking a survey, and the survey says to.
Yeah, I mean, look at the
I
guide.
got a
That's-
survey from you in the mail yesterday, man. Okay, I'm going to take it all the way down here. Should I use well, just want to ask, because people are going to be asking this, should I take a guide catheter, trap liner, or should I take a extension?
Trap liner extension. So there's two ways to walk out his.
Aside.
I think an extension would be easiest here. You have to still, even to get it,
You need a trap
you have to
balloon.
get,
I don't
you have
think
to
you
take
can
it
get a
out,
trap
right?
liner
So-
up there.
I mean, I think either one of them, but I expect, and tell me if this is right, Manos, I expect to feel a little more pressure on the wire because of the bend in the Supercross. As I pull it out, I'll do this, yeah. Because if I bend this, I'd let it be me who bends this. These extension wires are, the other side? Yeah, it's a little usually.
I mean, to me, the trapping secures it.
Yeah,
And also cuts radiation. Not that you care about radiation because you're impervious, but
I am impervious because of the.
yeah, exactly.
Because of the ramp.
I don't
not
think you have a
the
trap
patient
liner in
isn't.
now, though. So
So in other words, so you guys would have used. I guess it doesn't matter which, right? But you guys would have used the trap liner.
it doesn't matter. I mean, just a trapping balloon of any sort probably would make
yeah.
life a lot easier, and you don't have to use a dedicated, device like a trapper or
just a
trap it. Just a 2.5 or 3
2.5
balloon,
balloon at high pressure.
and then high pressure, and then be able to walk it out.
Now this step on fluoro.
So just to be clear for the
it does take
audience,
a little longer. I get it, and it's something I'm trying to use more trappers. But of course, what I like about this is I don't have to I don't have to rely on the balloon. It's sort of me doing it. Let's get the Turnpike LP or Corsair XS. Okay, get a Corsair XS. What do you guys think? Which one?
I think they're interchangeable, whatever you want.
someone called out a fine cross from the audience, or
Oh, and another thing is the fine cross that I learned yesterday was a great one. What would you guys use? Just take a note. This is the kind of thing people want to hear. I want to hear.
I do the excess.
What do you?
I always use the XS.
I think it has more push,
Corsair
that's
XS.
all, than the.
Sorry, I didn't hear you.
the majority say XS. Of the people who voted, the majority say Corsair XS.
But I would honestly, I put up a trap line or two at this point.
At this point, right, so-
Because I don't like the way your
Really
guide's
good idea.
bouncing back there.
Okay,
and-
trap liner, 6 French. Let's use a 6 French trap liner.
And this will allow you to
Don't put that on
maybe
yet.
change your wire and all those things, and you have a trap liner you can exchange. it.
Yeah.
So let's do this, Paul.
Yep.
Curtis is like his valve is
That's
expanding
fine.
as we
Okay, but
speak. So
he
let's
saw
go-
what I did. He saw why I needed you guys, so
Okay.
he's not mad at me.
Paul, we see you. What's going on?
So so I basically, let me see. So I got this through. I was able to get this is a Corsair XS. This is over a Gaia. And where I am right now is using all your ideas. I've got the 6 French trap liner in there. And I got past the first lesion. There's a second lesion here. Once you give it don't inject. Pull it, now inject. I pulled the guide liner back. We're just having trouble getting through this.
Interesting.
And then once I get through this, we'll change for a wiggle wire, and I'll start to try and dilate. But the question is, how do I get through this? I have to say, this backwards twirling, I'm just not as good as righty twirling. And, God.
So you may want to dilate the first lesion to get your guide extension better positioned. You may have to do that because you're about to lose
I'm sucking
the
away
whole
all
kit
of
and
a sudden,
caboodle
aren't
there.
I? What just happened here? Let me just
Yeah,
sort of
that's
coming
the-
back now. I don't like this. I do not want to lose everything I worked so hard to get for the last hour. Okay, so you think a balloon down here might be helpful, right? Okay. Well, let's get this.
Yeah,
Try one more time. I think you might be right.
Or it might be your first lesion is so calcified that it's hard to.
Yeah.
Yeah, yeah, yep. I did get this thing through there.
I would just
and down
balloon
to-
Yeah, I saw that, and then it's.
The thing
looks
is, your
like you got
Mongo's
stuff.
pretty, and we don't like to do a lot of work over the Mongo, but it's in a
Look
safe
at that
position.
guide. You see the guide?
Huge
It's gonna
vessel.
come out. It's going to come flying out, and that's going to kill me. I don't want to do a lot of work over the Mongo. On the other hand, I love to get a wiggle wire down there, but on the other hand, why can't I get this thing to
It's
doing right?
embedded-
You know what?
it's
I'm turning
embedded
it
in all that
righty now.
calcium.
I don't know why. Maybe it's because I'm better at righty. And now I've gotten it back down there. And now I have to get the guide back in so I don't lose it. The guide liner back down. I'm going to continue to see what happens with two hands.
See if you can get some.
I'm going to think down, not push it down. And it just doesn't want to go. Okay, this second lesion is going to just wants to kill me. And I'm giving a little tension on the wire too with my right pinky here every once in a while. And I think it's
I
working.
think
Yeah.
maybe getting.
It's gonna
past
go.
it, no?
I may even be. The other question is, should I just sort of take this wire out now and exchange for another wire now? What do you think of that idea? How many would do that?
The problem is getting a wiggle down from there will be challenging. You use
I
a-
think, why
use
not,
a
I
Grand
mean,
Slam or
why, there's some suggestions here about just getting a rotowire.
Hey, that's not a bad idea. Give me a test. That's a really good idea. Because, I mean, it sounds like I'd probably have to do rotoblader anyway, right?
Looking like it,
Yes, sir?
I'd say.
Okay, I'll take it back a little bit. Boy, that's pretty good, Perry. Perry didn't want to inject because he thought the guide liner was a little too far down. I got to give him some credit for that. Let's just,
I think you're through the mid lesion, you're through the prox lesion, Paul. So
so I can do a roto
Yeah, just
wire
take
now,
your
right?
And I
drive.
mean, the current contemporary rotowire will go.
Okay, so why don't I do that? Give me a Rota Contemporary, whatever that is. Rota
Modern.
C, Rota Flex, Rota.
it's called Rota Drive now. Is what
They
it's called.
They changed the name so they can charge more money. And I had the laser. By the way, I had the laser warmed up. We're getting a new laser that doesn't need to be warmed up soon.
That's
I'm
gonna
gonna
be
see if the rotor wire-
life-changing.
I'm going to stay with you to try to get the
Yes.
rotor wire down. If we get it down, then what we'll do is go break away while I get rotor set up. Is that all right, guys?
Yeah.
Yeah.
Then we'll just burr. What about atropine or a pacemaker?
You can give aminophylline and not have to worry. Manos actually published this where you don't need to give a pacemaker. You can just use aminophylline.
So aminophylline, I've never used it for this. Let me ask my nurses, do you guys know the dose or how we would do it?
Yes, we do.
Apparently they do. Does anybody in our team use it?
Yeah, so
I
just-
used it a couple of years ago. I think you have to call pharmacy, don't we?
Yeah, so just for the audience to know, when you do atherectomy, what ends up happening is you end up shearing red blood cells, which releases adenosine. And so that's what results in the heart block, and aminophylline is an antagonist, and so prevents that from happening.
But what about atropine? You're saying that will stop you? That works higher up in the
That
cycle.
goes back like
of
20
spiral
years.
here. Is that what you're saying?
Yeah. What is it, 300? Do you remember the dose, 300? It's coming to my...
And so, do you give it like
I
a bolus?
Manos, do you remember the dosing?
You know, I mean, you could. I mean, here many people would
a
not do
short
anything.
runs?
They just give some nicardipine or adenosine and do short runs and not give either aminophylline or a pacemaker.
It goes so easily.
And then you see how it behaves.
And then I'll take the regular torquer.
You know, I hate it,
Straighten out
but
the
personally in this
wire.
situation, I
Great.
put a
Doing great.
temporary pacemaker.
Paul.
Whoop. He doesn't like that. Okay.
His hands are moving across the table. He might be getting tired.
I think you may be in the branch.
You're in a little branch.
Because we're occluding the
Want
flow.
to check? I don't think you're in the main vessel, distally. Yeah.
I think
You're
it's
in a
coming
branch.
out there. Yeah, you're right, Jeff. What would I do
I'm just echoing Bruce here. I have no
what would I do
original
without
idea.
you?
There we go.
What would I do without you? How many years have we been working together, Jeff?
I'm his translator.
Okay. That good enough, guys? Want me to go to lower branch?
yeah, it looks good.
I think you're...
Okay, good.
I
All right,
think
so why
you're-
don't you guys do
You got
talks?
about 100 millimeters of throat.
I'll trap out this rotowire because you guys.
Let's see if Curtis is ready. We'll go back to him. We'll see him on the screen. If we don't see him on the screen, we'll go to our next lecture. All right. Let's see if Dr. Tierstein and Dr. Wu, I see, and Matthew, I see you.
Okay, well, I'm taking deep breaths here. Let me tell you what happened. Rotablator with trap liner. First of all, it doesn't work through what we're told from the package is it doesn't work through a 7 French trap liner. 7 French guide liner, yes, but not a trap liner. I don't know if anybody on the panel have any thoughts about that.
Yeah. Oh, go ahead, Darcy.
Yeah, I was just going to say, getting it through a guide extension is exceptionally tough. I mean, you have to front load the guide extension with the rota if you want to do it. Usually, I try not to have a guide extension when trying to do atherectomy. It just makes life so much easier.
Okay, now you're going to hold the wire straight. Okay, so I'm going to talk you. What happened is you're exactly right. Who just said that?
Darshan.
Darshan. I should have stayed with you. You could have told me to take the extension out. Well, it doesn't work. I went to a 7 French guide liner, and then it turns out it got stuck at the extension, just what you say. And of course, when it got stuck at the extension, you won't believe this. By the way, I made an extension right now to get this part done. This is a hard case. I will need an extension. When it got stuck at the extension, everything came out. I had to rewire this whole thing again.
Oh, no.
Yeah, and you know I don't get mad very often. I don't get like.
No, never.
Yeah, well, I was like pretty not Tearstein-like on this. And now I've got the Corsair XS, and of course I don't have a guide extension, so that got going down.
Just
So
real
I
quickly,
think-
was it easier to wire the second time?
Only because I followed all of your ideas. I mean, that's why it was easier. It was definitely easier because I went right with the 120. I mean, actually, honest, I tried with just the XS. I figured now there's going to be a hole there. This shouldn't be a big problem. And sure enough, it wouldn't go. I had to do basically the exact same thing, a Mongo that I made a secondary bend on. I mean, the whole thing. I need a new rotavider, please, for this now. And so now but fortunately, second time was, the only thing I missed was Berlakis' talk, but I got it on tape, see. I get to watch all these. But so now I've got this down to where we got it last time. We got a rotowire coming in. Yep. And the only question is, no, you don't have any more talks, right?
Nope.
We're actually on time. All right, good. Well, how about you stay with me for this part, since when you guys left me last time, I sucked and screwed this up. And even though it may be boring for some.
So, Paul, you don't think you could pre-dilate and get an IVL around that first lesion and avoid the rota?
You did a new extension. Okay, you don't need an extension. So I think
Just rota.
that we might be able to do that. But then what if we can't? I think it's good. Look, take a vote on the panel on that.
Like if you put a wiggle down now and took a small balloon and got it up to, and then just sequentially balloon dilated and then IVL.
I mean, I think he might be able to do that, but it may be like a whole another 3 hours to get all the.
Yeah.
That's exactly what I'm
And I think he used up all the 1-0s yesterday, if I remember it correctly.
Translate
So.
for me.
I hope we got room. That's a good question. Do we get it in
translate
stock?
to
All
me.
right, this is as far as I got it last time, I think. Let's get the rotowire, and I'll see if I can get it that thin. Let me put a bend on it. So
I mean, the roto's going to cross, right? So I think that's the
New
safest.
rotowire, please, by the way. I bent the tip of it.
Yeah, Jeff, I would agree. So I think
down and knock them.
I think kind of highlights if it's so hard to cross with a microcatheter that upfront atherectomy is the way to go. You might still need more of a debulking or lesion modification
That
afterwards.
rotowire, please.
And Paul, what burr are you going to go with?
We use a 1.5 generally to start. That's what we have out here. Thank you for running and getting that. Okay, so one of the things this is the kind of thing Bill likes to talk about. What I need to do is slow down a little bit. I just pulled this wire out, the rotor wire out of its hoop, and I bent it. That's what happened the first time. And this is kind of like me being a little too adrenaline focused.
Fatigue and frustration is understandable.
Yeah, and I
And you
gotta
work
make
an
sure-
hour and a half to get into position, but
Yeah, and
you just got to take some
wire
deep
is
breaths.
coming out of here.
So
Blame the
something-
fellow,
Paul mentioned the videos he saw. So the conferences, the presentations will be online at some point down the road.
Some of them are online.
Yeah.
It's bent me. Okay, so let's take this off.
Well, will you give atropine or aminophylline, or we just going
So
to
we're going to do some. So good question. Should I do I'll take care of that. Should I do tell me about aminophylline. You guys have it? I mean,
Yeah, so I just pulled
So,
up
do we start
Monos's
it now?
paper. Essentially, the way it works is 250 to 300 milligrams given over 10 minutes.
So
before-
while you're doing the rota, at the same time of the rota.
Just before it.
Right before.
Yeah. And so it's given over 10 minutes. Now, it causes mild hypotension transiently, and then that resolves, and then you're good.
And ends the asthma attack at the same time.
So, just to be specific, so you have to wait 10 minutes and then do the rota, or you just start it?
No, you could just start it, and as it's going, but infuse
So,
it over 10 minutes.
so I've got the wire down now. I presumably will not pull the wire out because I'm going to do a different type of. I'm not going to advance it by hand. I'm going to advance it with the. Can you step on fluoro, please?
Yes.
I'm not going to advance. I'm going to advance it. I'm going to dynaglide it up. So presumably I will not lose my wire again if I go slowly. Okay, I've got wire. Switch places, and let's get the rota.
Yeah.
And whoever wants to put this in, I used to have a beautiful rota loading system that we can't sell, which is unfortunate. Not enough business. I used to have my little platform had a rota.
What's the patient's rhythm? Any heart block?
No, everything's good.
Heart rate's
Everything is-
normal?
He's actually been wonderful, except he keeps moving his legs, and I have a problem with that because I keep thinking that's going to be a problem, but it's actually not because we're radio. But my instinct is to get upset. It's kind of funny. All right, so we're going to platform one more time, and you got the water going in. It's the rotor glide going down. Is that on? Yep, it's gone. So let's put that on. Okay. So you push it anyway. Yeah. Got it. Okay, now let's hit the button, please. I got this. Not that button.
So he put on, the drip is on, there's the clip, the brake on the back.
180. Push the button, please.
He's going to platform. Paul likes to go at 180. I'm more of a 160, 165 kind of person.
What we're going to do here is I'm going to come out a little bit longer. I'm going to do this as so slowly that no one's could be boring. Okay, just let me go slowly. I'm going to go walk back and fast. I'm going to do a lot of this myself just because I don't want that to happen again. I'm going to slip this in here. But before I do that, let's get it into the, so if you hold the wire, okay, just hold the wire. I need to get this device into the TUI before I can do the dynaglide. So just pull back on wire a little bit.
But you don't necessarily have to. If you just keep the TUI open, you'll hear a little, as it goes through the O-ring, you'll hear a little.
True?
Yeah. You'll hear a little, whoop, and then, but it'll go fine.
I never knew that. I figured I'd be ripping up the valve or something, but let's do it that way. And that's why I learned
Just make
something.
sure your TUI's open,
My TUI is,
or your Guardian.
my Guardian is clicked open.
Oh, beautiful.
Okay, so now can you just push
You're gonna
this
lift,
button?
yeah.
And that wire is going to get bigger on the outside. Just push the button. Okay, now help me move
Now
the
lift it up.
device.
Thanks.
I mean,
And
Okay.
Perfect. So you see that, we don't see his hands, but you see that the wire is getting bigger in the back of the Roto Pro. That's because he's advancing the system over the wire. The wire is stable. The Dynaglide is about, I think, about 60,000 RPMs, I think.
Yeah.
Yeah.
And that, because of the,
Wow, that's 1.5? Oh, you must be really
that
mad.
look big for you. Just because I was on the Mag 3.
That's what I was saying.
on a
It's the
wire.
biggest 1.5 I've ever seen.
Isn't that great? You have that instinct, though. I think it's terrific.
Yeah.
Okay, now we're ready to start with. I should close my TUI. You shouldn't tell me. You didn't tell me to close. my
oh,
TUI.
sorry,
That told me
I'm not
everything.
there with you. I apologize. Emmanuel,
It was
what was my question going to be? Was what RPMs do you think? I mean, what do you use? What's the difference?
Well, typically 160 to 180. Now, if you have super tight leaves, sometimes it will go to 200, 200
Yeah, I'm
plus.
going right.
But I think here, 160, 180 should be fine.
Yeah, I mean, you can go up to 220.
Okay.
I mean,
Again,
they had,
because
the
you
Japanese
have,
have done
you have to have
randomized
atrophy,
studies
just,
showing
atrophy,
that there's no
naturally, a whole
increase in
amp of
adverse
atrophy.
events.
So much for the amylophenol.
So okay, we don't see the
We don't
Mac
have
lab.
we don't have the hemo.
Oh no, we have we missed about 6 beats there.
And we're just starting, so.
Put up the hemodynamics there, Steve, if you could. I was once working with a fellow, and he was rotablating, and the heart stopped completely, and he just kept rotablating. Do you see that the heart is not moving? Did you
All
give
right,
an amp? You gave an amp already?
So let's do this, Steve. If you could put maybe the MacLab, the hemos in a small box, like picture in picture, and then we can see the fluoro. 'Cause we don't see fluoro. Yeah, there we go. This will also work.
How was the deceleration, Paul?
There you go. Nice.
Sounds great.
I think you have enough throw to get the distal
Okay, so I
lesion
got
too.
down to there, and I'm going to float my.
Yeah, Paul, show us how you float it down, please.
So to get some more, let's get my hands on the camera, if you could. Because this is already pretty far forward, I'll make it a little farther further. Woo, look at that.
Well, we don't see fluoro. There
I
we
want to
go.
pull it back. All I do is I kind of push this forward with my right hand, and I pull on the wire a little bit, and then all that happens is this knob floats backwards a little bit.
Yeah, it gives you more throw.
demonstration of that.
Yeah.
Good work. I found it harder with the Rotor Pro to do that compared to the old system. That was nicely done.
Meeting some resistance there, aren't you? That's where your micro got stuck.
So is the patient getting aminophylline now?
Nice.
You can't hear
I think
me.
that's enough. You want to go? Hey guys, you want to go? Should I go more? This has been great so far, but let me show you how long the lesion is. I don't know. Maybe I should stop there.
Yeah, I
that's
think
enough.
you're
Yeah,
gonna.
I think
you're
keep
good.
going.
That's,
Whatever you
that's
want,
the
yeah.
main thing.
Yeah.
I would go around the turn because there's so
Go
much.
around that
calcium
next
in-
turn. Good. Give me a chance to show the floating again.
There we go. Nice. That's
Well,
it.
sort of an air ball. Yeah, good.
Gonna float it again. So this is interesting. So it's having trouble getting around this one, huh? Put your hand down by your side. Someone can help me do that. What?
Little Ravines.
Well, that's a.
All right.
Okay, I'm gonna stir a floor of that. All right, so good. So we got this out. Hopefully we don't have a perforation. Could I have the back end of that? And we're gonna leave it on, and we're gonna dynaglide this out. And then we'll, I just got a bend on it. Could I have a hemostat? This is like a,
Yeah, it's just gonna say this is what
So
like,
you can either straighten it out or just break it
I'll
off.
straighten it out, and
But you
we're gonna get a microcatheter over this and get a wiggle wire in there and start probably shock waving. Now what time is it? Oh, it's 9:30. It's not that bad. So we'll need the Corsair access on this system, which is okay. Okay, Dynaglide's on. Now this big loop here is going to get smaller, guys, and keep all the stuff away from it so we don't get in the knot, and make sure all of these wires and tubes come back. Okay. So I'm going to start this. I'm going to go on. Let's see what happens. Open up my TUI. Just doing it nice and slow. Straight back. And then I don't want this to fall on the ground if I can, because if the burr falls, then you pick up all this debris from the towels.
Yeah, you can also leave the.
Okay, stop.
You can
Turn
also
that off,
leave
please.
the
Push that
advancer
button.
there and just pull it
Take
back
this
and
out.
be careful to loop it.
Okay.
One more time, Jeff.
No, you can leave
We're
the
going to take
advancer.
the
Take it back a little bit. And just pull
Corsair
it and
excess that I
just
have on the
loop-
table,
just
please.
loop the,
It's got
shaft.
caught for some reason. What is
Just a
going on
little
here? Oh my God. Oh my God. You're not going to believe. Oh, I got it off. You know, if the bend had got a little, the tolerances are very low in here, so the bend causes a little problem. This bend on the end of the wire. I can break it off with a hemostat, and I might do that.
You have wire cutters?
Well, you know, if you take a hemostat, Jeff, and just click it back 3 times, you break it off. You do get a bit of. Where's my cheater? Where's my cheater?
Or you can
The
take two
other thing is,
hemostats.
if you have issues, you can just parallel wire with a workhorse wire. Now that you've created a path, and so it should be easy to go
It's a
with
phenomenal idea.
workhorse wire.
Yeah.
Okay, good. So if we do it, we have IVUS made up, right? Good. Okay. We'll probably do some ballooning and then IVUSing and then shock waving. Okay, we've got that there. And here we go. We're going to get a wiggle wire next, please. A short wiggle. And the other thing I haven't done yet is put a the guide catheter or telescope back on here, which I probably should do. Probably should be just a 6 French, don't you think? So it goes all the way down if I need it. We've certainly modified this now. Let's get this down into here if I can. Okay, wiggle wire. Okay, we'll take that, give you that. And so when we take, I'm going to show this again, this trick. Manos, I know you have like a book with all these techniques, don't you, Manos?
Yeah, trying to keep
So
it
that's an
up to
important
date.
for folks to know. Manos has a book where he describes all this, and all the details. It's like great for fellows. It's great for anybody.
Well, he also has great YouTube videos. So for those
Yeah,
of us
really
who
good
can't read books,
Does he have
much
TikTok
easier.
videos? That's the question.
So Manos, do you have the concept of this? What I'm going to show right now, which is that if your wiggle wire is out into a branch that's about 2.5, you usually can just pull. If you keep everything straight, you just, I don't know if you look at my hands, I'm just going to pull and twirl back and forth a little bit, and it stays where it is. You don't have to do an exchange or anything like that. Now let's take that extension, whatever we had. Do we have I think we should use a 6 French for this. Do we have a 6 French telescope or something like that? Let's do that, and then we'll, actually, before we do that, we got to do IVUS, so that's another thought. We have a 7 French telescope on this.
could I make a plea for a picture just so we could get an idea of what the modification
Do you want a
looks like?
picture? What a
Yeah,
great idea.
I'm very visual.
What a great idea. No perforation. Okay,
Interesting.
well, we're done. Okay, so we have a 7 French guideline, so we can do IVUS through it easily. This is a telescope, okay? And then we'll take an IVUS. You want to take an IVUS catheter, or you want me to balloon first? What do you
I
think,
you
guys?
may, just balloon a little bit to create space.
Yeah.
That way you
So
have
let's
no
take
issues with the eyes.
a 2.5 balloon. Make it. What do you think? Compliant or non-compliant?
Non-compliant.
Okay, 2.5 by 20, non-compliant. Pink box. Pink box. I'm sorry. You said non-compliant? Okay, yeah, we'll try that. I think it'd probably go down. If it doesn't, we'll use a compliant balloon.
I mean, the dilemma here is that massive eccentric nodule. I mean, sizing the stent is going to be difficult. It's wondering,
have to get
I mean, it's probably worth,
You have to get IVUS done. Huh? You have to get an IVUS done.
oh, yeah, no, but I'm just saying, I'm thinking past this. And ultimately, with that degree of a gigantic nodule, it's tricky. I mean, it's a question of how much you're going to.
Shockwave getting ready.
The shockwave is gonna
It's likely going to be a 3.0.
You have to IVUS it.
Possibly a
Yeah.
3.5.
How much
Possibly
rubble
a
you got?
3.0.
It's going to be huge.
Goes all the way down or almost all the way down? Yeah, it goes down to here, right? Pretty good. That's what we want, right about, well, where do we want? We went all the way down here, really, don't we? Let's give this a test so we can see what we're doing. Inject. Yeah, we're going to want to go all the way down to here, right? Take it up there, 10, 12, 14, 18, down. 18. Down. 18.
But it is interesting how the nodules form in those bend points and the stress points, which is so typical.
Now go to 18 again.
How old is this gentleman?
And down. Why is the calcium on the outside of the vessel so? It shows you how thick these vessels are. Okay, a little test here. Okay, we're making progress, I think. I didn't see anything. Do you see any problem there? Perforation? Nope. Does the side branches? Okay, good. So let's get the IVUS down.
That proximal balloon went up surprisingly well.
I mean, there are descriptions of the calcium being shattered within the nodule, making it more malleable to flattening, but I still don't know how I actually resolve the stent sizing here. You put a full size, like probably a 5.0 stent here, whatever the IVUS is going to be.
Okay.
That's a problem, I think.
I'm starting to calm down now. I really was very upset about losing the wire on that case. And it was totally because of the guide extension catheter. It really wasn't anybody's fault, guys, just so you know. It
I
wasn't
think
their fault. It was
compared
the
to
guy
some
hit
of
the
us,
body
you kept
extension
your
catheter.
cool more than a
Like
lot
a
of us
snack.
would have, Paul.
Next time we want to see the angry screaming, Paul. You should cut back.
Yeah.
It's really
should have-
not
yeah.
like me to do that, but I was like, wow, how could that
You
be?
should have fluoro saved it.
Yeah, by screaming. Let's go on record here. And, thank you, Steve. I keep calling Steve Dwight. That's the funniest thing. Dwight was our AV guy coordinator for a long time. All right, but Steve has been for the last 20 years. All right, so this is the distal reference. You can bookmark this. You can give it a little injection if you want.
That's a
Okay,
four-way
inject
down.
there. Okay, good. That's all. the way
That's
down
your
there.
that's your co-registration there.
Yeah, that's my co-registration. So 1, 2, 3. It's 4-0 vessel, isn't it?
Yeah, we should really measure it though, rather than doing.
Okay, we will.
Well, you-
And then that's
well,
the
this
kind
is
of
the Avigo
intermediate
Plus,
lesion.
right?
I did
So-
dilate it already, but we're going to want to fix that. We
Well, it's
look to see
fractured.
how much calcium is here. Should we do shockwave or should we?
I think these you
what
fractured.
about that area? What do you think about that
There's-
area?
you
So
got
let's do that.
fracture.
Yeah, you smashed the glass there.
I mean, that's the distal lesion.
Yeah.
Yeah.
And should we use a 4-0 shockwave or should we use a? And there's or maybe I don't. Nah.
Well, there's so much shadowing, it's hard to measure the
I would
artery
use a
right
4-0.
there.
if you're
Very
gonna use one.
eccentric.
But it seems to be distally a 4, so well, it is.
So
but
what do
you've
we
got
have?
a lot
So
of
there's your
fracture,
dissection.
Paul.
Proximal. Look at all that. Look at the hematoma there.
So that's from your guide, I think, from before.
Let's make sure we bookmark that, and that's going to be our proximal test there. Yeah, and then we're going to get into the proximal vessel, which is this is good. That's your bookmark actually for the. So give us the distal and proximal reference. Do you guys think we should do shockwave or not?
I think so.
Yeah, I
So
don't
do I.
think-
I think why do you want to do it, Paul?
Because it may be helpful.
It might be. There are cases where I think you absolutely need to do it. I'm not sure you need to do it here.
Either
You've
do I.
got.
Okay, I agree. So tell you what I'm going to do. Give me a 30 NC 24 30.
So here's
that
why
way
I would do
I'll
it:
get
is if you get a shockwave down to a 4-0 shockwave, you have good expansion all the way. Do an angiogram, you have like a 30% residual stenosis, then you just put in a stent, and your perforation risk is very low. Versus cranking in C's in this tortuous calcified vessel. That's I think it would just be a safer way to go.
Yeah, okay, so we're going to take a 4-0 shockwave. Everyone agree on that? So we'll take a 4-0 shockwave. What length do you guys want? Oh, they only have one.
They only have
Okay.
one. Yeah, it's 12 millimeters only.
We'll
You
take
may
the
need
length
your
they have.
guide liner again for this.
You can hook up the shock, yes. Oh, I should use a guide liner again, right? Good idea. I'm going to do that, but let me do this first.
Yeah, Paul, I have a little housekeeping item to ask you about. So it's
Yeah.
it's 9:45. We're supposed to break at 9:30. So we could either keep you here until 10 and then take a late break. We could take a break while you're doing some work and come back to see where you're at. How do you want to do this?
For me, it's fine. Take it up there.
So this is your NC balloon now.
Yeah, go to 1820. Down. This balloon goes to 24. I just want to make sure I get the shockwave down there. I mean, I just don't want to struggle anymore.
Well, you may not need it if this
Go it
looks
again.
good. So.
I don't know.
But this balloon I can take to 28 atmospheres too.
think-
I mean, the 3Os.
Certainly
down.
don't need it down there.
No.
So if I
the
get
proximal.
balloon expansion, well, there's a couple of good questions. If I can, this is a 3-0. If I get this fully expanded, take it up there, 18, 20, go to 24 actually.
The IVUS was very helpful. It went by very quickly, but there was very good fracturing
Okay.
all the way through the distal and the mid part of the artery. I
Okay.
didn't really see the proximal. That's the one area where
it
I
up
think
there.
you may still want a shock.
No, we'll see.
The proximal area.
It's coming
Yes,
out
I know.
nicely.
If I shockwave
How
there,
are you
if I
gonna
can't get
improve
full
on that?
expansion
Yeah, it's coming
down.
out really nicely. I agree.
Listen, guys, what about if I can't get full expansion? I just shockwave afterwards.
You
Yeah,
can
you
do it
can do that,
afterwards.
but it's
I think, Paul,
not recommended.
Yeah, let's get a 404.
there is no way a shockwave is going to make a difference at this point in this case.
You've been against shockwave from the very beginning.
No, I love shockwave. I told you at the beginning, pre-dilate and use a shockwave. You don't have to rota. But now that,
That
you've
is true. He
rota,
did say that. I attest. He did say that.
you've rota, you've done what you needed to do. Now you just need to put some stents and expand them. Your 3O NCs expanding, no problem.
The only counter to that is right now what you're doing is you're expanding the non-calcified wall. The area off the nodule, not the nodule.
You notice I got
The shock wave potentially could make the nodule more malleable, but I don't know how you predict that
Yeah, but also
or even measure it.
if you have a well-deployed 4.0 stent,
Well,
that big.
and you remember we're late too, so
I
maybe I
agree.
should just put these stents in. Give me that.
I would not shock him.
I like the fact that you measured because sometimes we'll say, oh, on the IVUS, we're looking across the room, oh, it's a 3.5, but you really need to measure it. Sometimes you're wrong.
Yeah, so, but Paul, the balloon you used was a 3.0?
I used a high pressure 3.0.
Yeah,
and
so I mean, one of the things you may want to consider is use a 1-to-1 size balloon before you put your
Yeah,
stents
but-
in, just to
yeah.
make sure there's appropriate expansion. You
yeah,
may want
that's
to.
something to consider. I agree. But I consider.
So what would you use? Would you use a 4.0 or a 3.5?
I'd say 4.
I don't know.
So after this one, we'll take another stent. We don't know what length, but even if I use the sled, you wouldn't know the length.
Is there any way they can drive by the nodule again on the IVUS? Give us that. I think that went by really fast.
Let's see what happens here. I notice I got this. Oh boy.
Right, that turn there.
Yep. I'm gonna put my wire down further. See if I can get the 7 French guideliner. But went down pretty
good.
far. You see that? We're gonna have a little low pressure. Don't worry about it.
There we go.
Come on, buddy. Okay, that's probably what I want. I'm gonna ask you to give me an easy test there, so you don't dissect anything more. That's pretty good, right?
Yep.
Yep.
Okay, so by the way, why don't we ever stent guideliners and telescopes? Do you know why? Take it up there. 14. Because I've tried to do it on the back table. You can't. 16.
What happens?
It doesn't. The stents don't expand enough. Down. So now we have to come up with a length. I'm not going to even take this guideliner back. I'm going to leave it here. I'm going to use this stent. This is 48. So let's take it to about where we want it. Oh, boy, that's nice. I like the guideliners back down there. Ooh, wow, that's terrific, Paul. Let's see. I'm talking to myself. Can you give
like
me a
versus a
little?
good-
No, just a tiny. That's not going to really do it.
Yeah,
Let me just do my head. By
I think maybe a
half of 48 is 24. So we need more than that. How about a 30?
33.
What do you think? 30, 34?
So everybody says 30, 34, somewhere around there.
Don't shoot.
Yeah, go longer because
You might as well
you also
overlap
have to
when it gets to
hit
the
that hematoma proximal to the
So good point. So
nodule.
30,
Yeah.
38 maybe. Okay, 4038.
And you're definitely going to have to do pot.
I'll take this out. Of course, we'll do stent IVUS at the end too. Make sure everything looks good. Who said not to do shockwave? So far, so good. We haven't done the top one yet, though. Let's take it. The back end. Yep. We are getting you to your break.
It's all right. We'll just shift things a few minutes.
Yeah, I've got a valve. Curtis has like the coolest case. He has a really tough unprotected left main with impella in the next section. And
Paul, I have you slotted for a talk in the next session.
I'm coming back. That's why I want to do I'll do my it's a Navitor valve that that needs about 10 minutes.
All right, so you'll do that first and then come over
That
here, right?
was the hope.
Okay, got it.
It's a little bit long, but not bad. Okay, so I'm going to put this in too far. Can you give me a test here? I'm going to put it in a little up.
Oh, that's that. Oh, that's not bad.
Okay, hold on a second. Let me make sure I get this down far enough and then pull it back. That's a better way of doing this. So if I get it down a little too far, and then, wow, boy, it doesn't want to go. Got the wiggle. Let's take this down. Okay, Paul.
It's just the proximal edge of that stent, I think.
And I didn't do my, well, I think I'm in the stent now, don't you think?
Yeah, you probably are. You want to do a stent viz. You may just barely be not.
Oh, I'm just barely in it. Okay.
Maybe get the guide extension further down.
Yeah.
It might help
So I'm
you
going
get
to take the
back in.
guide extension further down, but I also can take the balloon and dilate the inflow, which I usually do. Maybe I didn't do for some reason this time. And that usually helps because it may be floating, you know what I mean? It probably is floating. I don't think it's going.
I wouldn't waste time. I'd balloon it.
Yeah, let's get give me a,
Can you get your guideliner down just a little bit more?
So what size was this stent? Was this the 4.0?
4.0. Could you guys get me a 4.0, just a pink box, just a compliant 4.0. I'm trying to get this guideline, but it's a 7 French guideliner.
There we go.
There we go.
Yay.
Now you should be able to go.
Oh, just riding the outer wall.
Wow,
you
it's
know?
still banging up against
So
it.
this is what a wiggle should do for me, though. It should get me away from that.
Well, but you
Moving the
did you
wiggles
move the
around.
wire a little bit to get on a different part of the sine wave?
I'm moving the wire. I'm moving it forward and backwards with my left pinky. And also it's got wiggles on it, but I'm not slipping in across it. So let's just do it right.
Yeah.
It'll take 2 seconds. Let's get that I'm going to take a compliant 4.0. You have it? 15, 20, 12 or something like that. Okay, and then we'll take the stent back, and I'll look at the stent to make sure I haven't, dinged the stent. The wire. This is like a. It's a very good problem-solving case. You see how the wiggle is right there? It should kind of be in the right spot for this. That went down. Take it up there, 10. 12, 14. I used a compliant because I wanted to get through. 16, down. Actually, what I'll do now is this, if I can.
I think it's also easier to go over the compliance with the guide extension. They're not
do you think? Is
winged
that
after
in
you
there?
deflate them.
I think it's down there right now. Yeah. We're through. Okay, good. So let's get the stent, and it'll go right in.
A little under expansion, perhaps, of that stent right there, right where you're.
You know what I'll do is,
post-dilate.
this will be fun. We'll do a poor man's IVUS also after we put the stent in by doing stent viz, or stent boost, as some people call it. And then you'll see the stent angiographically, which is really cool. Where's that here?
Paul, you saw that the entry point there looks underexpanded there.
Yeah, that's
and,
what we just said, yeah.
and so if you put a second layer of stent before you expand it, I think it's going to be slightly problematic.
You think it makes a difference?
If you put 2 layers of stent in that underextended portion, it'll be harder to expand.
I think you want maybe you could just, well, while you're there, his point is to post-dilate. I mean, you could get 1 millimeter of overlap, but
Yeah.
you saw that last cine, how there's a bit of an
You're
hour.
going to have to push it further down, right? And I think the overlap may be past that point.
You don't think I'm down there? You think I should do what do you think I should do besides put a stent down right now? It's not going. You're right. You're right. Oh, no, it's going now.
Well, his point is
No,
maybe
no,
take an
it's
NC.
not the delivery of the stent. It's the fact that there's an area of underexpansion, and the overlap may result in 2 layers there, and then it's going to be harder to treat after the fact.
Why is it harder to treat after the fact? You think the shock wave doesn't work through a stent?
I'm saying you might not even need a shockwave. You just NC it up front right now, and then deliver your second stent.
I'm not sure what you want me to
I
do.
guess it's not, he's just saying that if, let's just say that area is underexpanded, and let's just say you, right there, and you put another layer of stent, and that's the most you're ever gonna get, just for some reason, you've now reduced your lumen diameter by whatever stent this is,
Okay.
the thickness.
The
So
stent viz,
if
please.
it's 0.8, 80 microns,
So
it'd be
this
160
is going to be, so for Steve, this is going to be, you need that other screen for the stent viz thing that you're able to do?
Yeah.
Never mind, it doesn't work at all. It didn't work at all. Yeah. Okay, I think we're pretty good here. Let's
Yes.
take a look again.
I would bring
But
the stent back just a little bit.
When it's inflated, maybe do the stent viz. We could see how symmetrical or asymmetrical the balloon
Yeah, well,
inflation
okay.
is.
I see
Whether you're stretching
okay,
the
I've
wall.
double layered the unexpanded part of the stent. That's your point, but I can't bring it back much further, can I?
Yeah, you can.
Maybe a millimeter or 2?
You're overlapped by a centimeter, so I think
But what about proximally, though?
you got some
You
room.
need a longer stent, too.
You might need to put another stent in proximally. I don't think you need to finesse this too much, Paul.
I do.
I don't know.
I don't think I have to put another stent in proximally.
I think you got
This is
plenty of
perfect.
length.
Yeah, I think you got enough to pull it back, though.
Now that's
Yeah,
better.
pretty good. Take it up there, 10,
Oh, there, farther.
12, 14, 18, and 22.
So
Looks good.
We'll leave it up
yeah,
there
can
for
you
just
do
10
the stent
seconds here.
viz on that just to see we could see where the wire
I don't
is?
think stent viz will work, but while it's awake, just do stent viz and we'll see what happens.
If it works, if it doesn't, it doesn't. So
Does it work with a balloon?
So what's your point of doing it with the balloon up?
Does it work with this balloon?
just want to see how where the wire lies in the balloon,
Oh, that was yeah, that's a good point.
just to see it, while you're just
is like the
stretching
new thing, is the wires on the side of it.
non-calcified side, or is it more symmetrical?
Come on down.
You can see it's central, the distance.
So stent viz was worth
There
this,
it
but-
is.
But this was the idea that I think Ziad was telling me that if the new idea that if the wire is on one side, that means the calcium, that means it's eccentric. Is that true or not?
Yeah, I think so.
I never noticed. I never looked at the wire inside the balloon. See how with the balloon
It's helpful.
and how? So what does it mean? You don't see the wires on one side here.
It means you're stretching the normal part more. If it's on,
So that means-
if the wires towards the top, towards the top and towards the if the balloon is mainly on the inferior surface expansion, that means it's mainly expanding that, and there it is.
Okay, don't do. I sure do. Okay, here, guys. Let's reconnect. I got to close this up here. I got to get this balloon down. This may be hard to do. Give me a pink box 40.
Not these is full size.
Okay,
You got it.
take this thing up here. Take it up. Go to 10. 6-8. Oh, great. Wow, what a nice case. Okay, I got to get get the pericarditis tray.
You're
Go to
good.
12.
A little
I got to
bit
get a
of
covered stent. I got to go. You have to get. Let's get the femoral artery on the other side. We'll do it carefully. Okay. Wow, who would have thunk? We need ultrasound. I'm going to make sure we don't have any blood here. We need stat echo, exactly. Okay, so maybe that's very interesting. Maybe the shockwave would have been better. Say again? Do we? Oh yeah, we do. We have the ringer now.
Oh, the ringer balloon, yeah.
I've never used it, but we got it. Let's bring it in the room. Well, you
So
see
we
where
have,
that
we don't
problem
have a
is.
4.5, we only have a 4.0.
Oh, can we get a? We need. Echo. Okay, we need to get another senior fellow in here, and we need to get the left femoral artery. So the pressure's going to be low because of me, not because of him. I think.
And you can, maybe your
The pressure
guideliner
is
can
a low.
back
I
with
may
it.
have to do pericarditis here. Let's get the echo.
Paul, pull your guideliner back a little bit. Maybe that's would be the pressure would be better.
I am doing that.
There we go.
I'm trying to figure out whether he put his hands at the side. Trying to figure out what's going on here. It's a big perforation, so I do not want to. Let's get the echo in here because I'm probably going to have to tap him.
You know, he's getting quite ischemic too, so the ringer might not be a bad idea. But the second access is the key part now. Second access, ping pong.
Let's get a quick echo. Let's get the
Yep.
ramp part out, and I'm going to get changed into to lead. We need a second-year fellow in here.
And there should be an anesthesiologist in the room next door.
Yeah, if there's an anesthesiologist free, that'd be great. But if not, it's okay. We'll deal with it. Okay, we might have to do CPR. Let's get going here. Let's get people in the room. I need my lead.
So, Paul, we'll go to a break, okay?
So-
Or you want to stay?
Help me with this. Help me. Take that out. But
So let's come off.
get me.
Let's come off the hemos, please.
Okay, so this is a.
Mic's on. Thank you. We're back. Paul, we see you.
Okay, we're just going to do a quick echo. If someone could do a quick echo on his.
Yep, try and get in the code.
Okay. Yeah, well, I'm going to have to do this. All right. I'm going to need. Do you have the pericarditis kit here? You got everything? Okay. I just want to.
Oh, he has it too. Give it to him.
Mike, Perry will be able to do it. I'm going to just put my needle in here. Doesn't love that. Is there a pericardial infusion? Let's just make sure there's a pericardial.
We need to see fluoro, please.
There's no.
Two.
I think I.
Okay. We need those. Or echo. We can't. I guess we're not connected to echo, are we? No.
So can I have I need a syringe. I need a syringe. Okay. We have to get in here.
So, Paul, you may not have tamponade, right? How is your pressure?
Pressure's terrible. Pressure's around 50.
Okay.
Okay, I'm hitting something here. Come on, baby.
There we go. We have heme is back. So if we can get echo, that'd be wonderful.
We have he can't, he's doing a hand on.
It's okay
I
if you
got
did hand it-
pericardium, I believe. So let's step on fluoro.
We need to see fluoro, not hemos, please. Thank you.
Let's make sure that we have.
So the wire you see is following the border, And he's in
I'm
straight
in,
AP,
right?
and it's going all the way to the spine, almost the
let's
other side
get
of the
this-
spine. So,
all right, so
he
guys-
is definitely in the pericardium.
Okay, good. So now we need to get in. Can I get the needle?
The
Scalpel,
dilator.
please. Scalpel, please. Put that on there. You can do what you're doing. That's fine. And
Make sure they have the 8 French sheet. Now, sometimes you have to get an Amplatz in there, but let's see if you're.
So you do some CPR. Looks
the
like
needle,
there's no
this is
pressure.
a blade. Okay, now. Okay, that's fine. It's a dilator. Dilator's in. Now we're going to put something bigger in.
This is the drain.
I don't know if we need intubation yet, but we have to do this first. Okay, let's get this in. Look for an Amplatz guide wire in case we need it.
I don't have wire.
So get some 60 cc syringes ready.
We need some
You
big.
can also call. I mean, is there a lot of blood in the pericardium right now, or just a little bit on
We
echo?
think there is based on the echo that we see here.
You got it, Paul. You got it.
What are you doing in the wrist? Oh, okay. All right.
It's okay. It's
so
fine. The
we're
wire,
gonna
but his sheath is in, so he's great. He's
Yeah, I
doing
think
fine.
it may be.
Sheath is
getting
in.
caught- It is?
You know, one thing you can think about here is a cell saver.
Okay, if you want to give
to
this
save the
back
blood
to
if there's a
patient,
lot of
that's
blood.
fine. Okay, so the blood pressure is now
go
40,
yep.
and I'm taking blood out. Blood pressure's already coming back with this out. Okay, so now we want to take another couple of syringes. If you want to give this back to the patient, you can.
So I would just put it in a bowl. Put it in somebody grab a blue bowl. Put the blood in the blue bowl and put like 3,000 units of heparin in it, and then. If you call perfusion, they can get a cell saver ready. If you can't stop
Okay,
the
so
bleeding,
the next thing we're
give
going to
it
need to
back.
do is get the other groin to do a ping pong approach and get the covered stent in here.
You really don't want to put that blood back into the arterial circulation.
So I've
That's what's
gotten
critical.
3. So you see what's happening to the blood pressure
Yes,
now.
it looks
Blood
great,
pressure-
Paul.
All right. You're going to do the femoral?
Yes, Frank. Can you change the?
So your blood pressure is great now, Paul.
This is a needle, so get rid of to take that.
So
I need to move this to flow the groin.
Okay. Yeah, we'll do a couple more.
But it won't.
I'm gonna move the table that way.
The big. You guys want an airway? Go through a 6 French.
Well, does he need an airway? Yeah. Okay. All right, because you know.
our blood pressure is 120
back.
now, Paul.
You can do it quickly and easily. I'm not hurting him. Fine.
All right, he has control of the pericardium. That's it.
All right, I'm gonna floor.
Frankly, I would just.
Some more syringes. This is blood that can go back to the patient.
Do you have a
Just
coconut?
wondering if you could put the papyrus in a 7.
You can do either way. Either groin is fine.
With a single.
Blood pressure is 140 now, Paul. You're doing great.
Yeah, give him
Does the
some.
patient get any pressors?
Yeah, give him some hydralazine.
I need to see the 390.
Yeah.
The EKG is a little bit better.
It's interesting. The STs are coming down. Somehow there was maybe some compression by the fluid and causing more ischemia.
Yep.
One
Because
more
you can have constriction of the arteries with the
Okay.
pericardial
Next thing.
fluid there.
Oh, he's waking up now. His blood pressure is obviously fine.
Okay. All right. Good.
If you intubate, just do it. I've gotten all the blood out now. Okay, I've gotten all the blood out. Nothing more is coming.
Terrific.
We just have to make sure we do a good stick here.
Key thing again, Christine Schenner,
Can't have any
fantastic structural
more complications.
fellow.
Everything-
Using
everything's
ultrasound
stable.
guidance.
Do a nice stick, a normal stick. No big deal.
Pressure is great. EKG
So
is
Manos,
good.
is this
Take our time.
following your algorithm, your famous tamponade algorithm?
Well, I mean, this is exactly right. I mean, the 4 components. The first one is put the balloon up, which he did very. I think that helped a lot. Otherwise, he would be bleeding. It was a massive. There's a pretty big perf. So that's number 1. Number 2, call for help, which he did. Of course, tamponade, pericardiocentesis, which he did. And now the question is, how do you take care of the real problem? And I think, given the size here, it's unlikely it's going to. Sometimes the balloon inflation can help you seal it, but this is massive, so I don't think this is going to work. So I think what he's doing is exactly the right thing. Get femoral access, a big 7/8 French guide, have the wire ready, preload the 4-row papyrus on the next wire, get it ready, pull the existing guide back, engage with the new guide,
Right up.
balloon down for a second, wire
Wait for a-
quickly,
a
put the
sheet,
cover
could
stand,
be
and that should
it
take
could
care
be
of
a-
it.
What do you got, a 7 French or? Okay, can we do it? Does a 4.0 go through a 6 guide? I guess it does.
I think the shift
4.0
is the
covered stand.
4.5.
It's best to use a 7 if you have.
Yeah.
Just for
I think the
support and-
4.5 needs a bigger guide.
if
right?
you can
I think
still
the-
put a
up to
7 in,
4,
I would
think
do
you're
that, Paul.
okay.
Matt, do we need a 7? Matt Price, do we need a 7 French guide for a 4.0?
You don't, but we all think the support to get it down because of the
Can't hear Matt.
tortuosity.
What is Matt saying?
Use a
Seven.
use a
Use
7
the
for
7.
backup.
Okay, well, let's get a 7 French sheath in here then, guys.
That's not for delivering the.
How about a 7
this-
French sheath?
That's in order to make sure that the
French sheet.
papyrus stent can get around
I
the
would like a
turn to
7
give you
French-
more support.
All right, we can take the 8. We'll take the 8 French sheath. The per close on the way out.
So things are fine here. The blood relatively
Yeah, but you have
fine.
to-
Blood pressure's okay. You have access. You now have airway control. He's certainly not continuing to bleed because
No,
his
we
blood
got
pressure
the, we
is
got the
fine.
blood stopped.
So this is where you can take a breath, which is and make sure you get good access without. You don't want. We have one complication and it'll often lead to another complication. Then you have your third complication.
But
and
that's
things
just
aren't good.
my sheath going in. We didn't numb it up as much as we could have. That's all. Give me an ACT syringe. ACT syringe. Here we go. ACT right here. Okay, good. So and we can give him back that blood. Let's just. Okay, I want a guide. This was. Let's take a.
You said you wanted a picture.
Oh, yeah, okay, we'll do. Why don't we, yeah, all right. Can I have a syringe, please, to flush this? Is that a flush syringe, or is that the? Just give me a flush syringe, guys. Actually, I could use the, give me the contrast syringe. You're right, you're right. You're right.
All right,
We'll
so
just, we'll just shoot it and make sure we got a good.
he's gonna look at the groin now.
Okay, so we have blood, we have meds, we have ETG, we have a color changer. You got a color changer?
Needs to pee.
It's a little bit of a low stick, but it's all right. Okay, good.
Better than higher, I would say. In this
Yeah.
situation.
Okay, so let's take a an AL1 with side hole guide, and a whole nother indeflator, a whole nother setup because we have to manifold. We have to.
So,
we need a second manifold.
so Paul, this is what we're gonna do because things are relatively
voice.
stable now.
It's horrible. What is that?
What? Paul, we're gonna come back when you have everything set up because it's gonna
Okay.
take you a while to get
If you
things.
want to come over here and help me, that would be great.
I almost, by the way, when I saw the perf, I almost ran over there, just so you know, but I figure you'd be okay. I'm like, oh, God.
We're doing fine. Everybody's doing what they're supposed to do. I'm not sure we needed to intubate them, but they were here. Better
Yeah,
do
for
it
sure.
now. And, he's stable. Actually, ST segments are a little bit up, but we're going to do the ping-pong approach. I'll fluoro save everything, and we'll get a covered stent in here and solve the
Okay,
problem.
and we'll be ready, I think, to come live by the time you have your stent ready. So.
Have a guide extension there too.
A guide, get an 8 or 7, at least a 7 French guide extension,
Yeah.
just in case the papyrus won't go, right?
Yeah. Yep.
All right, that's a good idea.
Because
thank you.
that papyrus will go through a 5, and a 7 French guideliner is about
Okay,
a 6.
so
Yeah, and
we'll
what
take
size
a
papyrus are
moment,
you gonna
get set
use?
up. Everybody's doing good.
What size papyrus are you going to use, Paul?
I didn't hear you.
What size covered stent?
So I think a 4.0, unless they have 5.0s.
I would use a 4.5 if they have it. I think
they do
They
have a 4.5.
They have 4.5.
All right, so I'm going to ask Perla to come
One
back.
of the issues, Paul, is
Where's
careful
Pearl?
with the guide extension of the papyrus because it can come off. I think Ajay's telling
Okay,
me. But
that's a good point. So, hey, I'm Paul.
It's 5.0. I see that. It was a 5.5 approximately, so I think I'm going to use a 5.0 covered stent.
Okay, but
maybe a
Paul,
4 is enough.
Yes.
Paul,
You don't want to-
Emmanuel had a very good point, a careful point that maybe the guideliner may not be a great idea because you can shear off
Okay.
you can pull off the covered stent. Emmanuel,
You have a
watch
big,
it.
it's an open vessel there. You don't need, it should be easy to deliver. You don't have any calcium. I mean, you have the big stent sting already there. So delivery should be okay.
and
what's
so,
your point?
and also the 5.0
What's the
could
point, though?
not fit very well into the guideliner, the 5 millimeter. So,
Should not use a guideline.
correct.
Okay, good. That's good. It's hard to hear over there. They got a suction thing in there that's making it hard to hear. Or maybe I'm deaf. All right. All right, any other ideas before you guys have a cup of coffee and, some croissants?
No, I think you've got it covered.
High five, right? Yeah.
Pun intended. Okay, we'll take a break, but we'll come back. I'll alert you guys if
Okay
we
with
come
it?
live. Okay, so let's come off cameras.
Okay.
Okay, terrific. Paul, we see you now, and we see your fluoro.
Let me go back and so apparently I got more upset when we lost the wire than I did during the perforation crisis. But let me go over what we did while you were gone, having your tea and crumpets. So what we did is, okay, so there's I did a lot of work while you were gone.
Yep. Okay. Here's the
So
sheet.
we put this balloon. Remember, we put the balloon back up, and I took about I don't know 300 cc's out of his pericardium. Blood pressure came back. The stat team did a very good job. They intubated him. He probably didn't need it, but why not? We stuck the groin here. It's a bit of a low stick, but I think we'll sort that out. Then I got my AL1 at 60. We're going to pull it back a little bit. Guide in. And you'll see that I kind of worked carefully to make sure it was really in. See how it's really in there?
Yep.
And then I got ready with a wire and a microcatheter, and I let the balloon down, and I think I have this all caught here. Maybe not. That might not be it. That's not.
Here, no. Okay.
And you know what? I got the wire down. Maybe I'll show you that again. This was the one. This is the one where you can see the wire. Eventually, I got it down. It was actually kind of hard. I had to take the microcatheter
See that.
and use it. Actually, use it to give it body. And I don't think it caught the whole thing, but I did get it all the way down. Well, maybe it did. Yeah, here we go. See, and that was sort of how I got it strong enough to get it down there.
Hey, Paul, this is Ajay. One thing just for the audience, it's important is that if you're having trouble, once the microcatheter is there, you can go back up on the balloon again. And then you can even give blood through the microcatheter, but basically it allows you to have control with the other guide balloon system and then manipulate with the other one. So that's the
I'm
real
sure I understand that, but let me just go through this because we have to do
Yeah,
something
go ahead,
here.
Paul. Sorry.
And so we got that down. Then we put the covered stent. This is the 5.0 covered stent, 26, the longest one. You see it's still bleeding there.
Yep.
And put it in and deployed it to about 18 atmospheres. I forgot to remove the wire, so pulled the wire and then the other wire, old wire, and then blew it up again, a little higher. And it looks pretty good there, but it's not perfect. And you see it in this view. Do you see that it gets? If you look at the left side of the screen, it's just not perfect. And then we thought it was coming more proximally. Curtis was really observant and came in and said, I think we got to go a little more proximal. And I think, well, here's a 5.5 balloon. That didn't really help it. So now this is a 5.0. No, it's covered stent. How big is this? 5.0? Yeah. They have a 5.0. It's a 5.0 by around 15, I think, 18. And I got it right at the ostium and blew it up, and the problem is gone.
Yeah.
Okay, so we want to show the IVUS now, because I went through it. And before we show the IVUS,
Let them applaud you.
that was pretty good. Guys, I got to say, I have not had one of those in a long time, and if I never have one again, I'd be fine. Let's take it up there to 4 and then keep going. Let's just show you the IVUS now. And Perla will go through it. It's actually pretty good except for one spot, at the overlap spot that you guys warned me about. You guys can give all the shots here. And so right here, and I did co-register that. It's eccentric. It's probably big enough. In fact, Perla, you can measure that, but it's pretty focal. And then Perla, what would be my distal reference for that lesion? If you want to, yeah. The distal reference, that's, yeah, even come back, yeah, right? The stent, yeah, that's good. What are you getting there?
1, 2, 3, 4,
4, 8. So let's take a 4.0 NC24. These are balloons that can take to 28 atmospheres, and see if I can get full expansion of that. I've done now shockwave. We don't have a marker for shockwave like we do. But this is we're shockwaving that area. And we're almost done. We've given all the pulses. I'm just going to do a quick balloon inflation. If it fully inflates, then I'll do an IVUS. And then we'll give the blood back that we took out. It can be about 20? Yeah, 18.
Hey, Matt, you mentioned something when he was in the Hurt Locker.
Go ahead.
You said, we have the Ringer balloon, which is a nice balloon to put in there to buy yourself time.
So we haven't had the chance to use it yet.
Yeah, I've
Have you
used one. I've used a couple, actually. They're really great for tacking
Yeah.
things up and buying time to think of what your next
so.
step is.
So it's
I
not
ask you-
really, it's not our typical balloon. It's actually a coil balloon.
Coiled balloon.
correct?
It's like a true flow balloon for valvuloplasty, sort of.
So I have a question about that because I thought that would be great, but then I got in the thick of things here. I had my stent delivery balloon. We caught it quickly. Some of you caught it before I did, and so I just blew up the stent delivery balloon. It was the right coronary. Maybe if it was an LAD. I mean, to get the ringer in, I'd have to take that balloon out, which I don't think that would have been a pretty picture without having, unless I did it as a ping pong. All right, so
Yeah,
let's
that
get
wouldn't have been a good idea.
Let's get the balloon.
Well, I think if you
what's the
had
length?
uncontrollable ischemia, you might ping pong, switch to that, and then go back, and then put your stent. I think you can put the papyrus. Some of the papyrus is actually through the ringer, can't you?
Yeah, but I think but Paul's point though is you definitely don't want to take the balloon you're having control with down to then make your exchange. You'd have to do it with a second.
How do you take the papyrus through the ringer? You wire the ringer?
Yeah.
It sounds like I need to learn about that. Are you sure? Wow. You put a wire through the inside of the ringer?
It's a hole.
Darshan, you want to talk about that?
Yeah, I mean, again, you have the way the ringer works is basically like a spring, essentially, that sort of coils on itself, and so as a result, you still have a lumen inside, so you can get another wire through, get your papyrus if you need to, and then pull the ringer out.
I see it there, right? You can see the lesion. Come
So
on down a little bit. I'm going to center this.
if
So
you
this is
deflate the ringer, it won't collapse on top
Get up
of
there,
your.
18.
No.
No, yeah, that's
to
where
the side, huh?
yeah.
How big is this? 4.0, right?
I'm saying, especially if,
24.
let's say there was this uncontrollable ischemia.
Right.
That would be a place for it, I think, where you would do the swap.
So one important thing about this is that this is an NC balloon. So NC balloons, you can take them to these types of atmospheres without worrying about really big expansion of the balloon. If
But you
do
can't.
it-
So look at the chart here. I've got this 24 up. I'm not going to tell you how high until I take it down, and we don't have a perforation because I don't want to. It's up at 24 now, let's say.
But if your pre-dil balloons, your stent balloons, all those balloons are going to be more compliant. And if you take them up above their nominal, then you start
How big
getting
is
much,
this?
much bigger.
4.0?
So that you have to be really
Where's
cautious.
this at 4.0?
That looks well expanded
24,
there.
It's about 4.25.
Yeah, that's about right.
That's about right.
They usually, the NCs generally go up a quarter in the 20s.
Exactly what I'm doing, and let's see what happens now. Let's make sure it's not. I don't have to put another papyrus down here. Okay, give me a little test here to see if we have a
A little
perf.
shell shock.
No perf. That was 30 atmospheres, so you know, on the NC20.
Could you
Let's give
take
a hard
that,
shot
something
can
here.
you
at the
do a
mid.
cine there, Paul?
Cine, yeah.
Please, cine.
That's just
Yeah.
Okay.
Get the balloon again down, right?
Okay, so where's my balloon? Come on, guys. Here it is. Okay, test there again. Okay, take it up here, 10. I can't believe we're doing this. 10. 10, go.
Well, the good news is it can't tamp the knot.
Okay, let's do the ping pong again. I got the other one here. All right, so we're going to need another papyrus. It's going to be the same, I guess, 5.0. Huh? And it's going to be about, what do you think, about a 20-ish, guys? Okay.
Say a 4.0.
Fortunately, I'm pretty well set for that.
You know,
I really
5.0 might be a little big. Maybe
Yeah,
4.0
just
might
take
be a
the
little
4.
better.
You think
Take the
4.0?
4. You can always
Take
make
the
it bigger.
4.
It's 4 down there, isn't it?
Yeah, can make it bigger. Okay. So take a 4.0 papyrus, about 20. I think I'm in here. Now, this needs to be cleared. We need to make sure. And we don't really need the, what about guideliner for this? This one has a guideliner on it. Do we need that?
You probably
Manos, I
don't.
think
You
were
have
telling
it
me that the
plenty
guideliner was going to
open.
be a problem, right?
I mean, as long as you're just very careful with when it's coming into that on-ramp
Yeah.
of the guideliner, you just have to be cognizant of any
Yeah.
resistance that may be felt.
Yeah, but once you're in,
Yeah.
then you actually have a lot of
Yeah,
flexibility.
then you're good.
Okay, so because I have the guide, was this a 7 French guideline? I think it is, yeah. Okay, so I'll put it in the straight part, and we'll see if it gets caught up. We have that balloon, so let's make sure we're using the right, yeah. And can you give me a test through this system, just to make sure I'm in? I think this is the first system, so it's probably that one. Okay, good. I'm in. Okay. So now we get to do 2 papyrus. Well, the third papyrus. This guy's. Now, what do we know about the long-term outcomes of papyrus in vessels this big? It should be pretty good, right?
It should be. I mean, there are published series on papyrus in a registry, and the outcomes don't look great, but I think some of it's the protoplasm, some of it's what happened during the initial case. But with big size and, good post-still,
Wire.
it's okay.
You also have a drug-eluting stent essentially outside it, so that would help with restenosis as well.
Yeah.
I have wire. Okay, so now we're going to do ping pong again. So it's going to be a matter of taking this balloon down, injecting. Who's got the injector? Matt has the injector. Now this is this papyrus trying to go through. Of course, it's going to. This case is like a whole course. So the papyrus does not want to go down, guys.
Yeah, so whoa, it's not on a wire.
No wire.
It's not on a wire.
What happened to my wire?
I think you,
Oh, I haven't done the wire yet.
Yeah.
I'm ahead of myself. This is a BM. What do I have? What wire is this? Is it a BMW? 'Cause that was about an hour ago. Let's see.
Because I think the wire that's down is the wire the balloon is on.
Yeah, guys, you're right. I mean, this is get me. We have to do this from the beginning. Give me a give me a BMW, please.
Right here.
In fact, why don't you give me a BMW? We'll put it. Here's a BMW. We'll put it inside a microcatheter that you have here.
Yeah.
And I'm going to do it with a microcatheter and another wiggle wire. That way I know I'll get it across. Microcatheter. You can give us a new one. Give us a Turnpike LP or something like that. Now, do you want to go? I want to keep things going.
Yep.
How about if do you want me to come back for the ping pong on this?
Yes, please. Why don't we I know Curtis has a case, and if Curtis is ready to
And I've got a patient in the next door. Let's go, guys. Okay, so you can
And
go
then we
away
have a
from
talk,
this.
too.
I'll come back for the quick ping pong.
Paul ready to. Hi, Paul. We see you.
Okay, good. Okay, guys, you won't believe this case. This is
You had
insane.
another perforation?
It's insane. No, 2 more.
What?
So wait, let's go over where we started.
Wow,
here.
more staining.
So this case is just amazing. So what happened is, I got to I'm sorry, I got to get back to where we had that. Now the machine has got its mind of its own. I clicked too many times. It's going back. Ah, God. All right, whatever.
Okay, here.
Yeah. This was the where we had that perforation at the edge, right? You
Yep.
see that? So we went back and we were able to do the ping pong, same old ping pong thing that we did last time, right? I'll speed through it then. Let the balloon down, get the wire across. I'm getting pretty good at ping ponging. I haven't done this in a few years, but now I did 3. Then we got another papyrus, and that I didn't want to get that branch. So I pulled it back a little bit from here, and I think it stopped before I put the papyrus in. But that looks great, right?
Yep.
Look what's going on up top.
Yeah.
Hold on. Wait.
You see that?
Yeah.
Yes.
It's
Oh, look
leaking
at that.
again.
Yeah. So let me show you again. Yeah. So I took
eye.
a bigger balloons in, and that's where I am now. I just put a 6.0. It was a 6.0 balloon, and I'm not that high. I'm at 12, something like that. And we're gonna 10 to 10. Then we're gonna take it down and see what happens. And if we're gonna do a ringer, I don't know what else to do but a ringer, and just leave it up for an hour.
Yeah, I agree.
If this is still bleeding. Okay, so I'm going to pull this balloon out. Remember, this is 6.0, so
this is
probably
also
it's
the-
going to be hard to inject hard. I'm going to pull the balloon pretty far back so you can
The
really.
good news is you have a drain in, Paul, so you have control.
Yeah,
I definitely do. Yeah.
If it's slowed down, I might just
Protamine,
say
right?
do some protamine and just have
Yeah,
a diagnostic.
protamine.
I don't see it anymore.
Protamine, Paul, and that's it.
I think it may have stopped now.
Yep.
But I would still give protamine,
Protamine, yeah.
honestly.
Okay, should I do a completion IVUS or not? Even bother with it?
No, I'm afraid you'd want to put another stent.
Yeah, I
Get out
think,
of
I think you
Dodge.
walk away, Paul.
Okay,
Take the
I
win.
can walk away.
Yeah, we don't want
and the
another
good news
case for
is,
next
so
year
So,
for.
but Paul's instincts are right, because the point with covered stents is that, yes, you're all excited that you've sealed it, but they can thrombose if they're not actually adequately
honestly, I would-
expanded. But in
I would
this
run-
case,
I would
you've
run the
done,
IVUS.
you're not going to, you would what, Jeff?
I would run the IVUS.
Yeah, I mean, just to make sure.
You guys got the IVUS?
So what are you looking for, Jeff, on your IVUS?
Huh? Just if there's any the
IVUS,
papyrus,
please.
any
IVUS, please.
focal under expansion that you're missing here. It's hard to imagine, but I'd just like that assurance, given the consequences of thrombosis here, and the
me tell you how long it takes to get the
and the
IVUS down
risk,
there,
given
about
all
2
the papyruses.
You're going to have an IVUS image in under 30 seconds, so why not?
So are you using a sled?
Yeah.
I'm going
We just had a debate about that again, Paul. Huh?
I'll come in the lab with you
Well, he's
tomorrow,
going to do this.
today.
He has an amazing 1 millimeter per second pullback with his hands.
Okay, so let's go on.
You could also go at
record, and let's see the IVUS.
6.
Good work, Steve.
You can go 8.
You're on
Yeah,
it.
but I mean,
Steve
you
could
lose
work with
them.
us in the cath lab.
Okay,
Done
no
so many
distal
of these.
dissection. Great.
We look good at the distal margin, and you'll see the papyrus coming in shortly. It's been a long time since I've
About now.
yeah. There it is.
Well, the area you were concerned about expanded, no
Yeah,
question.
that's for sure.
Well, the area, yeah, you're right. That's the area that we had eccentric and all that, and we got it open. We got it too open,
Yeah.
That's right.
bled. But man, this is like a friggin' great result here.
Yeah, it looks like a femoral.
That's it. I mean, let's see if we're just sticking out of the coronary at all. That's the guide. So let me pull the guide back a little bit, and then we'll see if we are sticking out at all. This guide likes to. Just want to know if I landed. I landed.
No, you're great. You're
Bullseye.
I
perfect.
landed it perfectly.
Yeah.
So this is, I mean, this also makes you feel better about giving protamine, frankly, because everything
Yeah.
in the area.
You really need to get protamine.
Okay, we're
I
gonna
would, just
Well,
because.
we did it ACT. It was like
Yeah.
300 recently. So you want to start with like 20 of protamine, guys?
A quick question for you, Paul. Was the patient preloaded with
Good
antiplatelets?
question. Take your syringe, please.
That's actually a great question.
He's already on Plavix. You know what you guys can do? You can get a PRU to make sure he's actually responding to Plavix.
Yep.
That would be helpful. I'm going to take, just because I like to have pretty pictures at the end of my cases.
So Dersh, if it wasn't preloaded, you might be hesitant for the protamine. Yeah.
No, I would say I would probably start him on Cangrelor and then
Cangrelor,
give
yeah.
the protamine afterwards. So obviously you want to make sure that you don't thrombose the stent with your protamine.
Because he's intubated now. I mean, you can put
Okay,
an NG
and-
tube down, but
That I think is great. Now listen, I'm going to go next door. My patient's been waiting for a valve, and when you can do whatever you need to do now, but I'll cut in when I'm ready to deploy the valve, and then I'll run over. And I could do my talk at lunch or even not. It's on RDN. I gave one early. I gave one.
I think we're going to be okay because we have 40 minutes, and so Ajay needs to give his talk, and then we can come back to you to do the
Okay.
Navitor. That's 40 minutes, and then you can do your talk later. Okay?
Right, or if I somehow, if when I'm ready to deploy the valve, I'd like to just cut into Ajay.
Yeah.
Because it doesn't take long, and he's been waiting, so I don't really want to wait any more than I have to.
Great.
Okay?
Thank you,
Right,
Paul.
super guys. Thank you all for your help.